I shall give you over the next 15 minutes an overview of the first consensus statement. First, what I shall be doing is telling you why we need an expert consensus statement for India. And then subsequently, we will come through how we came and what are the guidelines for the consensus statement in India that we are going to be doing. The first statement, as Dr. Narsingan had clearly identified and highlighted, came up in 2016. And the reason why we felt that we need a consensus statement exclusively for India was because of this. The risk for coronary artery heart disease is very high among the Indians. It is 4 times higher than the Americans, 6 times higher than the Chinese, and 20 times higher than the Japanese. And 40% of the patients in India are below 45 years of age. This is compared to about 5 to 10% abroad. So we seem to be having a very high amount of patients who are at a younger age group, and there is a higher prevalence of the traditional risk factors in these group of patients. Not only that, there is a very high prevalence of atherogenic dyslipidemia. We are confounded by the additional fact that there is poor awareness, and how to prevent them hardly seems to be existent. The dietary factors are poor, physical inactivity seems to be largely prevalent. So this makes India a unique ethnographic class when it comes to management of dyslipidemia, and that is the reason we thought we'll have Lipid Association of India brainstorming sessions all over India. And what happened was we had sessions all over India in 30 cities encompassing 18 states with 153 experts. All of them came together, all the meetings were videographed, very carefully edited, discussed, started out, literally fighting with each other, finding out what is going to be the best. And finally, we came up with a consensus statement. The first question we answered was, when should we start screening in this highly ethnographic, highly prevalent disease in India? So we felt that the universal screening should start at 18 years of age. And how best to do it? We told them that the best time to get into that is going to be at the time of college admission. So when you go in at the time of college admission, that is going to be the best time to screen. So when they enter college, screen everybody. You don't have to do a fasting lipid profile, because when you do a screening, you just do a non-fasting, because that makes it easier. Just to get a fasting sample, you need to get them to come back again. We felt that that is going to be good. And a non-HDL cholesterol doesn't require a fasting sample, and that can be useful. How useful it is, we shall be seeing in the subsequent slide. The moment you see a high lipid level, look out for secondary causes, and if present, treat them. Otherwise, what happens is, we came up with a very simple algorithm, nothing very complicated. All patients, once you have a lipid profile, are categorized into low risk, moderate risk, high risk, and a very high risk. Now, the very high risk obviously is those with atherosclerotic cardiovascular disease. This atherosclerotic cardiovascular disease high risk has been accepted. The very high risk also includes diabetes with 2 risk factors or familial homozygous hypercholesterolemia. Now, what are these risk factors we're talking about? Very simple clinical factors. What we are looking at is age, male more than 45 years, female more than 55 years, or a family history of heart disease where the male first degree relative is going to have a coronary artery disease at less than 55, or a female less than 65 years, smoking, hypertension, low HDL. All these are very well found out within your lipid profile and your clinical history. So you don't need any fantastic calculator. So with this, if you have diabetes with 2 risk factors or an atherosclerotic cardiovascular disease or familial homozygous, you have a very high risk category. The high risk patients are all other diabetics with, or somebody with 3 major ASCVD risk factors, chronic kidney disease, or an extreme of 1 risk, about which I will tell you. If you have 2 risk factors, you fit into the major moderate risk category. Low risk is going to be 0 or 1 risk factor. So very simple calculation. If you have 2 risk, you get into moderate risk. High risk is going to be 3 major risk factors, diabetes, CKD. So this is going to be the simplest algorithm that is going to work for Indian patients. Now, there are some additional factors that we have spoken about, the enhancers as people call it nowadays. Now, there are 3 major additional high risk enhancers. That is going to be the coronary artery calcium score, the carotid, and the lipoprotein little a. Now, if somebody is in the low risk category, if you have a coronary artery calcium score of 100 to 299, or a carotid intimomedial thickness that is high, or an LP little a of 20 to 49, you shift them into a low to a moderate risk category. Now, suppose the same factors are very high. Like for instance, the coronary artery calcium score is more than 300. There is a carotid plaque, not an increased intimomedial thickness, but if you notice a plaque when you do a carotid ultrasound, or if your LP little a is more than 50, that comes into a high risk category straight away. So if you have an extreme of these factors, that goes into a high risk category. Now, if somebody with a moderate risk has these factors, that goes up. Suppose somebody has got these high risk enhancers, that also comes into a high risk category. So you have clear, very high risk, moderate risk, and low risk categories. These low risk persons can subsequently be identified to estimate the lifetime risk or a 10-year risk of coronary artery disease. So we discussed a lot about which is going to be better, the 10-year risk or a lifetime risk. What we felt is age is a very major factor when it comes to calculation of 10-year risk. And we found out that the best risk factor that works for India is the JBS3 score. So if you use the JBS3 score, you look at the lifetime risk, and based on that, you can calculate and shift anybody from a low risk category to a very high risk category, which Dr. Narsingan had already alluded to in his introductory talk. Once you've categorized this, how do you select these patients and how do you treat these patients? The risk categories have been given as very high risk, moderate, and low risk. Very high risk, the target LDL cholesterol. So the primary goal is going to be LDL cholesterol is going to be less than 50. The high risk, less than 70, moderate risk and low risk are going to be less than 100. But if you look at the considering drug therapy, you try a lifestyle modification first, very sincerely for the first low risk category, and then only go for a moderate risk drug therapy in these group of patients. So very simple numbers, 50, 70, and 100 for most of these patients in India. Now, you start drug if you don't achieve these categories. Now, is these values safe? Now, if you look at the primary prevention trial, like the Jupiter trial also, the values were brought down from 108 to 55 in these group of patients, and they were pretty safe. Even in a primary prevention, these values are safe. If the LDL was looked at less than 50, 65% of the patients achieved, and in fact, 23% even achieved a value of less than 40 milligram, and that was found to be safe. So it is quite safe to have these values. There is a lot of stress on primordial prevention. Primordial prevention is prevention before the disease starts having. Look at the lifestyle factors and start primordial prevention looking at good, healthy dietary habits and lifestyle modification. That is going to be paramount. So the first step in the management of these patients is going to be therapeutic lifestyle change. I will not dwell into this because there is a separate talk by Dr. Satur who is going to be talking after me, and that is given a lot of stress, and we'll have a separate talk on the lifestyle changes and how it is going to impact. So, but one thing, you start with lifestyle change. Everybody must have a lifestyle modification in these group of patients. The target of therapy, we have already mentioned, is going to be LDL cholesterol. Now, how much is the LDL cholesterol? We already said 50 milligram is safe. So how do we treat it? The treatment is predominantly statin. So the statin is the primary modality of treatment. And once you've started them on statins, you check your lipid profile every 3 to 6 months to see that you're in target. The maximum tolerated dose of statin is given. And if you don't control with that, you can look at the other factors like the ezetimibe, the fibrates, the dual PPAR inhibitors, or the bile acid sequestrants. And now the PCSK9 inhibitor, which was not there at that time when we came from 2016, have also been coming up. And that will be discussed in the case discussions later. So statin and lifestyle therapy is going to be predominant treatment of choice. Now, what is going to be this non-HDL cholesterol? Now, if you look at non-HDL cholesterol, it's a very simple calculation. You take the total cholesterol minus the HDL cholesterol, you get a non-HDL cholesterol. Now, this is an encompassment of all the risk factors. It includes all the atherogenic risk factors, and it is also called as poor man's apolipoprotein B. So if you look at the non-HDL cholesterol, that has been defined by the Lipid Association of India as a co-primary target. The value that is going to be, if you have 50, 70, 100, you add 30 to that, you land up with a target for the non-HDL cholesterol. And how do you treat non-HDL cholesterol? You try to add statins, and if you achieve the LDL target, you still don't achieve the non-HDL cholesterol, your predominant treatment of choice is again going to be statins. The goal, like I said, is going to be 30 more. What about the other factors? Clinically, we are looking at certain other factors. One is the triglyceride and two is the HDL cholesterol. But what about the triglycerides? Now, it will be interesting for you to note that 30% of the Indian population have a very high triglycerides. What is the major risk? At that point, the major risk was a high MACE event and a pancreatitis. Pancreatitis is realistically there. Now, elevated triglyceride should be treated, and your target that you're going to achieve is going to be 150. But mainly remember two things. There are plenty of secondary causes of hypertriglyceridemia like uncontrolled diabetes or the hypothyroidism or the renal causes. Look at them, and if they are there, treat them. But the treatment of triglycerides is predominantly lifestyle because it can be very well controlled with lifestyle modification, dietary modification. So your first treatment is going to be lifestyle modification, which is going to bring down the triglycerides by 50%. And if you are going to achieve it, first shot is to try to do it with statins again. If you still don't achieve it, the non-statin drugs like the fibrates can be used at the discretion of the clinician to use it. The next thing that I wanted to tell you is about HDL cholesterol. Now, 2 points about HDL cholesterol. HDL cholesterol and its inverse relationship to atherosclerosis are very well known, and higher the HDL, we said, is better. Low HDL is an independent risk factor. In fact, it is used as a major risk factor in the Lipid Association of India. But pharmacotherapy is not useful. Having said that, remember, But physiologically, with lifestyle modification by exercise and other factors, if you start doing it, it is useful. So increasing HDL cholesterol by physiological means is going to be a very important modality to increase the HDL cholesterol. Don't go for drugs like the nicotinic acid, which have failed miserably in the randomized controlled trials. What about statins and diabetes? We have already always been worried about statin-induced diabetes. Now remember that statin-induced new onset diabetes is not very significant. It is dose dependent, and the risk of the new onset diabetes has been studied extensively with the CTT trialists, and they felt the risk was more than 50 times smaller than the absolute benefit. So if you want a 50 times benefit, why bother about a new onset diabetes? I think we should all be looking at treatment of the hyperlipidemia or the dyslipidemia, and don't worry too much about the new onset diabetes. What about statin intolerance with muscle related side effects? It is now being called as statin associated side effects and statin associated muscle side effects. The incidence is very less than 10%. Routine CKMB, CK measurement is not required. In fact, it is not recommended at all. Even there, if you have a hypothyroidism or a vitamin D deficiency, drug interactions have been important factors. Look for these factors, and statin associated side effects, remember, are not very common. Muscle related effects are uncommon, and you don't have to routinely stain for CK in these group of patients. What about the hemorrhagic stroke that has been found to be higher, but the risk is much less compared to the benefit in reducing the ischemic stroke. So you can still safely start using statins in these group of patients. There is no definitive evidence for cognitive impairment or peripheral neuropathy. This has been clearly proven wrong in randomized controlled trials. What about statin and liver? The incidence of the 3 times higher than normal limit of SGPT is found in less than 3%. In fact, all the guidelines, including the, say that routinely you do not have to measure the SGOT, SGPT when you're starting to give statins unless you have some symptoms. So you don't have to routinely measure. So statins, when you're looking at in primary prevention, the dose utilized is a very small dose. You either use a 5 milligram or 10 milligrams of 5 milligrams of rosuvastatin or 10 milligrams of atorvastatin. And at this dose, the side effects are much less. And in fact, the new onset diabetes is dose related, and that also seems to be significantly less in these group of patients. So the final recommendations are that these are the recommendations of an expert group of people. Ultimately, all of us should remember that an individual patient is most important. All these guidelines work well in the larger subgroup of the population. But for an individual patient, the application has to be defined by the clinician. So please choose your patients, apply the guidelines, but your patient is known to you and treat them. To finally highlight the expert consensus statement, routine screening is recommended at 18 years of age, exclude secondary causes, use the simple lie algorithm. Actually, I'll give it to you again in the next slide. If you still have a doubt with the low risk patients, use the JBS3 score to assess the risk for a lifetime risk. Stratify these patients to risk categories. LDL cholesterol is the primary target. Lower the LDL is better, but it is safe also. LDL less than 50 milligram has been perfectly found to be safe. Non-HDL cholesterol is a co-primary target, very important in Indians. Statins are the primary treatment, but non-statin drugs can also be used. No role for niacin in these group of patients. Practice primordial prevention in the general population. To finally summarize what I have said to all these patients, remember this algorithm: categorize patients based on the risk factors, the age, family history of coronary artery disease, smoking, hypertension, dyslipidemia. 0 to 1 risk factor, low risk, target LDL 100. Moderate risk, 2 risk factors, target LDL 100. High risk patients, any diabetic or diabetic with no or 1 risk factor, 3 major ASCVD risk factors, chronic kidney disease or extreme of 1 risk that we had already discussed, 70 milligram. Those with atherosclerotic cardiovascular disease, those with diabetes and more than 1 risk factor, familial homozygous cholesterolemia, these fall into a very high risk category, and target LDL is going to be 50 milligram percentage. Now, this is going to be the simplest algorithm. All of you should be definitely thinking about using it in clinical practice. Thank you very much for the patient listening. And I want to thank the organizers for giving me an opportunity, Dr. Raman Puri, Iyengar, and Dr. Narsingan for making me part of this. Thank you very much, sir. And now over to the chairpersons.